Hello. Hello, everyone. So I'm happy to be here today to speak of the really important subject to me and the personal anesthesia. So yes, I'm working in Israel on the Galilee Medical Center. This is on the north. Really beautiful place. So I have a conflict of interest with Medtronic company, and let's begin. So in the past 20 years, the world has changed. We have evolved. And it's really important for me to say that we have so much more ways to evaluate, to appreciate our patient now than before, that I did this presentation in order to highlight the underlying cultural shifts, change that happened. So I have 4 questions for us today. First of all, how do we prepare our anesthesia? In daily practice, I mean. Second, how am I? We are doing a good job. What is high quality anesthesia? And third, how precise I need to be on everyday practice. I need all the monitor for all the patient, for all the surgery. I'm not sure of that, of course. And finally, if we have time, we will speak about the patient view, the patient perspective. I keep the bibliographia, the evidence-based medicine, for the second part of the presentation. But on the first part, I want to share with you some clinical case, and I will be glad if you want to play with us. So let's begin. This is a very, very classical case. Okay, we have a bariatric surgery over than 100 kilos, and I want to do a classical induction. Okay. And my question is like that. What is your posology? What do you want? What will you do? Okay? So let's see in the auditorium. Raise your hand if you think it's a good answer. So answer E. I want to do fentanyl 250 micrograms and propofol 2 milligrams per kilo. Raise your hand. What do you think? It's a good? Okay. We will see. Second, answer B. Okay, a little less fentanyl, but a little more propofol, 3 milligrams per kilo. Okay, let's move on. And C, I want less propofol, less fentanyl. I'm reducing all the doses. So now let's think. What is the underlying question here? What's happened? If I'm thinking of what I learned in medical school, we had weight. That's what we had. We have to adapt the posology to lean body weight, to ideal, to predictive body weight, to weight. Because we have the MAC parameter, and the MAC parameter tells me that according to the weight, we need to weight to the parameter of the patient, we need to adapt the posology. But I don't think it's so true, okay? Propofol is working on the GABA receptor, and if we can adapt to posology, maybe we can think of the brain activation. Okay? So now I have to think in another way. We have to, okay, I'm understanding. Before, we didn't have a monitor to see my brain activation. So how can I adapt my posology? But now we can see how I am impacting, influence my anesthesia. So this is the next part of the clinical case. And we can see that we did answer C. Okay, answer C. 100 and 100, but every patient is unique. I need to adapt. There is no right or false answer. Every patient must be adapted to his own homeostasis. But let's continue. And this is my parameter. I have isofren expiratory 0.7, mic 0.5. On the middle, you have BIS from 40 to 60. And on the bottom, you have the spectrogram with mean frequency 2 Hz and the black pattern. So my question is like that. What do you want to do? You have MAC 0.5, BIS 45, spectrogram, mean frequency 2 Hz. You will reduce, you will increase your anesthesia, your isoflurane because of MAC. What we want to do? And once again, the underlying question is like that. What is the most parameter, the most powerful monitor to rely on? Okay? Because this is what I'm doing on everyday practice. If I'm looking for the MAC, my patient, I need to right now increase my isoflurane. If I'm looking for the number here, everything's good, I'm well anesthesiated, and I can maintain isoflurane 0.7. But according to the mean frequency, we are on delta. We are so much deep that we need to reduce my isoflurane. So it's really, really important. I just recommend you, for those who are not regular to see the spectrogram, this is not my YouTube channel, but it's a really, really quick learning channel, 5 episodes of 5 minutes, in order to see how anesthesia impacts the patient, in order to learn about the drug patterns, really powerful help. And also after that you will learn about the surgical modification and how it impacts my EEG. But let's see this video. I just want to share with you the third part of the clinical case. I can launch this video. How can I say? How can I do to launch the video?
Can someone help us, because this is a video and we want to demonstrate it?
Thank you. So 20 minutes after the beginning, we reduce the isoflurane, and you can see MAC 0.3. That means MAC it's not a good tool. Don't use it anymore, please. And here we can see the BIS monitor. And the BIS monitor, we were on mean frequency 2, and now also delta, and now we are alpha, mean frequency 10. Also, you can see the BIS number 40. Didn't move. But what we are using is the raw EEG, alpha, beta, and delta, and the spectrogram in order to manage our anesthesia. It's a really, really powerful tool, but also it helps me not to do bad things. We can improve our hemodynamic state because we're reducing the dose. It's really important because bariatric surgery is also in laparoscopic procedure. So it's also impacting my hemodynamic state. So let's continue. I am using the BIS monitor for the induction and for the patient, but also during the long surgery, for every surgery, we do know that the propofol or sevoflurane is coming back from the lipid, and if it's coming back, we have to adapt the posology during the surgery. And here we can see that during surgery, in the same amount of sevoflurane, my patient is deepening itself because we are not reducing the dose. So, to conclude the first part, we came from a predictive way of seeing our patient. We have, no, I don't know, diuresis. It's a milliliter per kilo per hour. But now we have preload optimization. Okay, for neuromuscular blockade, we want lean body weight, or no, total body weight. But now we have the neuromuscular transmitter. We need to adapt the posology. And I do recommend you to work with the BIS monitor now, because we can adapt the posology and we can improve all the parameters. So this is the subject of the presentation. Second question, with all this monitor, is there an order? Do you think that this is my operating room, and I have many, many monitors. So is there an order of all of that? Is this something you want to do first, something second? So let's think about it. This is the second question for us today. The second clinical case, I am taking over for a Ripple open procedure, and this is expected to last another 2 hours. I'm replacing not my best resident, and this is the information that I get. Hemodynamic, my blood pressure is 176. Okay. Heart rate, 52. And I am doing anesthesia with remifentanil TCI 4 and sevoflurane expiratory 1.9. And my question for you is like that. What do you think of this anesthesia? You are replacing your resident. You have to check him. Okay? First, I think it's a good anesthesia. I will not change anything. Second, the first thing I want to adapt, the first thing I have to think is the hypnosis. I need to check for the hypnosis. I'm not talking of all the parameters. I'm talking what will you do first? And is there a first to do? But we will speak of this. Second, I'm sure that my patient is over-analgesic with remifentanil 4, and I answer C. I need to determine the right level of nociception. And D, and believe me, this is not a stupid answer, because many times we don't care of the hypnosis or the nociception state. We just want to adapt the hemodynamic stability, and we will say that my patient is stable. So answer D, I just want to improve my hemodynamic state. And this is a really important question for me, because if I want to do a personal anesthesia, I need to think in order. I need to classify the thing. So let's see this in practice. Until now, the traditional approach was to see the hemodynamic as a final indicator. I can enter the operating room, I can see hemodynamic stability, and I will say, my patient is really stable. But it's quite difficult, because hemodynamic is also a goal and also a value. But now in personal anesthesia, every single parameter, hypnosis, nociception, and hemodynamic, become its own final indicator. So I need to see my hemodynamic, but just after I check my hypnotic state, my nociception state, and after that, only after that, I can speak about my hemodynamic stability. So let's see this picture. Let's say that this is my patient. I have two main parameters, hypnosis and nociception, and I want to harm him. I want to hurt him. This is surgery. And in order to help him in the excess of nociception, I need to put my patient in artificial coma. This is what I'm doing. I am using also an hypnotic. Oh, what can I do? Okay. Also hypnotic and also narcotic, let's say, in order to take care of my coma. And I try to remain my patient on those border. That means not over sedated, I don't want burst suppression or anything else, and not less sedated, I don't want to risk awareness or wakefulness. And also, I need to remain my patient on this border, this boundary, because here I'm over analgesia and I'm risking hyperalgesia and chronic pain, and less, also the same thing, central sensitization and chronic pain. So this is what I need to do all over the surgery, to remain my patient on this green square. And all over the surgery, that means according to the noxious stimulation of the surgery, and all over the surgery. I can add some powers according to the kind of surgery. Let's say I have a trend lumbar surgery or laparoscopic. I will measure the driving pressure. I can add temperature, anything I want. It's really important to me to be on the good homeostasis. But what's really important to me too is to remain my patient outside the danger zone. This risking zone, what is it? Really simple. The secondary effects are two kinds. First of all, we will harm our patient. It may be the brain, if we are over-sedated, or the autonomic system, if we are over-analgesic. And the second category of complications, it will be the hemodynamic instability and all the cardiovascular complications that we already know, like acute kidney injury or myocardial infarctus. So, this is my parameter. And I just want to remember you the first question of this part. What I'd say, I just want to know which one of these parameters, hypnosis and nociception, I need to take care first. Because it's not that true. You do know that if I want to do anesthesia, I can also use 500 milligram propofol and it will work. Or 1 gram fentanyl. And my patient will sleep for a good week. No, but it's important. Is hypnosis and nociception connect? And second, if those are connect, is there an order to adjust? Okay, so let's see in practice. I have a very simple picture, and after that we will begin the evidence-based medicine with the bibliography. So this is a patient, 80 years old, for a arm fracture. My orthopedist says that it will less than an hour, but of course it was more. And we did general anesthesia with laryngeal mask and supraclavicular block. On the supraclavicular block, we have lidocaine 1% and ropivacaine 0.35. As an adjuvant, we had dexamethasone 8 milligrams. After an hour, I get this picture on my EEG. And this is really important to me. What happened? We can see that here we have the good, or not so good, because maybe over, but alpha and a delta band. Okay, but here I can see more delta and less alpha. And my question is, do you think we can interpret that? A, no more alpha, my person is deepening. More delta, more deep. B, alpha dropout and no more on delta arousal, my patient is awakening. And C, and this is the most often answer that I have heard, we cannot interpret nociception according to the BIS monitor. So I put the two questions on side, and let's talk about some bibliography together. I just want to tell you that all the studies here changed my way of doing anesthesia in everyday practice. I came from a predictive, I learned from a predictive way, and when I see these studies, I change everything. So we begin in 2100, the inverse Turing effect. This is a really, really good study. They ask for 20 anesthesiologists to learn from sample patterns. Let's teach them a simple thing. And you can see on the raw EEG here, we have on the bottom the piezoelectric line with burst suppression. My person is over. Okay. Above, we have alpha and delta. My patient is a group did sedation. Above, the sinusoid pattern, the beta pattern, it's less sedated. And above, high frequency, low amplitude, my patient is wakefulness, is waking up. What's great, after they learn this very simple pattern, they ask them to estimate the number of beats during the surgery. Okay? And they succeed. After a simple teaching, they succeed. But what's really game changer for us, until this day, we didn't know what we are doing. And at this day, we are targeting the right level, the right impact of what we are doing. So the inverse Turing effect, that means that the human being is learning the machina in order to do good. And it's really, really important to me. 10 years after that, the team of Richef and Emery Brown, it's a very important paper I want to show you. The natural sleep, it's when the activated reticular formation on the brainstem is turning off the cortex. But the anesthesia is completely the opposite. And in order to get a good anesthesia, so this is my study, we are, from the cortex, turning off the hypothalamus and the brainstem. And this is really, really important, because from the wave I have on my, from the way I have on my EEG, we can correlate them to an area on the brain. And every area on the brain is an organ function. So I can get my parameter of my anesthesia and I can follow my patient now, not just on some waves that I have on the monitor, but also on my clinical application. I can see loss of conscience, apnea, loss of reflex on the pons, and atonia. So this is anesthesia. And I can follow my, in clinical practice, where is my patient. I can check for corneal reflex in order to see if my pons is anesthesia or not. It's really, really important, because if I continue, pain is also an organ function. Pain is really on the brain. We have the nucleus tractus solitarius on the brain. You have the afferent pathway, and the efferent pathway to the hemodynamic receptor. So, according to the level of sedation, we will get a different response with a different pain threshold. It's really, really important to me, because I can answer the first question. There are collected parameters. And if I have my patient is aware, of course I will feel more pain, but I will also be more respond to my energetic. And what we can see, it's really important, is that in my over sedation, I will not be more sensitive. And when I start anesthesia, I remember a old anesthesiologist, all the surgery, he was just giving fentanyl at the induction, not after. But also he has the most the higher amount of complication on the recovery room. Every patient was in delirium. Every patient was in vomiting and everything because he was using sevoflurane 3% for all these patients. But of course, at sevoflurane 3%, you don't have to use fentanyl because there is no brain. Okay, you are destroying the brain. So it's not that clever, and it's not that new. We learn from the Miller anesthesia that we have anesthesia is a combination of also hypnotic and narcotics. And we learn after in evidence-based medicine that we are reducing the MAC number, the holy MAC number, if we are adding fentanyl to our patients. So also I just want to tell you that MAC, I cannot use it anymore. I know that it only include the level of sevoflurane. That's what new for us. It's what new for this presentation that I can follow my nociception according to my BIS monitor. Because I know this is different threshold of pain. So I can answer the second question. First of all, you have to take care of the hypnotic state. Because on the hypnotic state, depending the level of responding to nociception. And this is a BGA, publishing on BGA 2019. And you can see here, we have a good alpha and delta. Okay. And here my patient is experiencing a nociception activation, and this is pain. This is not waking thing. After receiving morphine, we get back from the alpha and delta. And this is exactly what I have with my 80-year-old patient. You can see here with my alpha dropout and delta arousal. So I answer my question. We have to take care first of the right, we have to reach for the right level of for hypnosis, and after that, we can manage our nociception, and just after that, we will treat the hemodynamic state. It's really, really important to be all the time on my green square, but in fact, we can do more, or much more than that. If I'm looking at this graphic, I can also reach for no more than necessary hypnotic and no more than necessary narcotic. And I can be on the sweet spot here. The golden triangles is here. And here I can reduce all my side effects. Remember I will not harm my organs, autonomic system or my brain, and also I will not get hemodynamic instability. And this is a really simple clinical video that I just want to share with you. I came back from lunch, and before that, I have a patient, 15 years old, for post-operative ventral hernia, and we did a very good tap block procedure before the surgery, and it worked very well. So when I get out from the operating room, remifentanil was 1, and when I came back, it was 3.5. And what I want to show you is the same thing than before. If we are over-sedated with patient, we get hemodynamic instability, but if we over-analgesia with patient, also we get hemodynamic instability. We can play the video, please? You listen to me? Georgios, help me.
Can we play the video, please, on the screen? Thank you.
Just before. So, healthy patient, in fact. And you can see here tachycardia, a swinging oximeter, and a narrow pulse pressure. It's the hemodynamic instability, and it began just after I get out the operating room, of course. This is a null monitor. We speak about it later, but I can see that my patient is over analgesia. So by reducing my remifentanil, what I will get? I have tachycardia, but by reaching for the right level of nociception, I will get a normal hemodynamic stability. And my patient is no more tachycard. I have a wider pulse pressure, one 140 on 90, and my patient is no more in a difficulty. It's really important. First of all, we have to be on the green square, but on the golden triangle, it's much better. So let's continue, and this is the way I teaching my resident. First of all, neurologic state. Oh, clinic, we can appreciate the reflex of the pulse of everything, but we have the BIS monitor, the mean frequency. We have to seek for the alpha and delta waves and the good anesthesia. Second, I manage my respiratory system with microscopic and macroscopic. And third, I appreciate the nociception state. Oh, primary, because I have the BIS, the null monitor, and I can appreciate my balanced sympathetic, parasympathetic, or my vagal tonus. Or secondary, I can wait for hemodynamic change or respiratory change. And after that, only after that, I can speak about my hemodynamic, and also in order, first of all, preload optimization and afterload. And it's really, really important, because if I have blood pressure 180, I need to know before if it's the brain or if it's the autonomic system. And after that, I will know if it's the heart, the heart system. Why? Because you are not treating three of them the same way. And if I have 180, maybe because overall less sedation, overall less analgesia. So I need to think this in a step-by-step approach, in a sequential assessment. And again, it's really, really important to me. So we answer the second question for me. And when I saying this is a good quality anesthesia, for me that means well sedated, well analgesied, and hemodynamic state. Let's take a breath for me. And let's see this in the timeline. If I have a sample patient, 20 years old, for a sample procedure, and I'm asking myself, in the last 20 years, how much sevoflurane I need to use. According to the MAC parameter, I can use for him sevoflurane expiratory 1.2 at 2.5, and it was a good thing to do. After that, BIS told us that we need to keep our patient from 40 to 60. So I reduced my window from 1.5 to 2, let's say. But now I have a narrow window. It's really important. I do know that and I targeted it. I need from 1.6 to 1.8. And according to this window, I need to manage my nociception in order to improve my hemodynamic. And it's really, really important. It's the start of everything. And why this is so important, I have the final study on this chapter to show you. It becomes an independent factor of morbid mortality. This is from this year, Anesthesiology 2025, and we can see that reaching for the right level of sedation, it becomes an independent factor. Like you say to your resident, mean arterial pressure 50, it's not good. Or everyone knows that we need more than 65, or according to my chronic disease. But we do know now that if we are over-sedated or patient, it's something logical, in fact. We already think of that. But here, now, it's evidence-based medicine. It's more than 1,000 patients, more than 1 year follow-up, so it's a big study, okay? And we can see that we are reducing the morbid mortality just because we are reaching for the right level on the spectrogram. So we have to think, we have to understand that this is the future, but this is the present. We need to do a good job. It's really important to. We are giving for sevoflurane or anything else to our patient in order to do good. But if we are giving more than necessary, the good becomes a poison. It's really, really important not to reach for the right measure of our drugs. And this leads me to the third part. Because if I need to be precise, let's be precise in everything. Let's use every monitor for every patient. But it's not that accurate. Let's think of this in a different way. Let's say that we have two categories of organs. We have the supporting organs, like lungs, kidney, muscle, and for this organ, I need to be on the right hemostasis and to keep them on the right hemostasis. But I also have the target organ. The target organs, that means that they are being altered by the anesthesia. And every time, I need to seek for the right measure of everything. So for the brain and for the cardiovascular system, we do have many, many monitors. But for the autonomic system, most of the time we are just waiting until we have hemodynamic reaction, respiratory reaction, or if my patient is moving, maybe it was good to give him fentanyl before. So the Medicine Society think and reach this monitor of null, and we can see quickly how it works. On your left, you have the noxious stimulation of the surgeon. On the middle, you have my sympathetic and parasympathetic balance, the vagal tonus. And according to this activation, we will get a sympathetic activation, and after we will get a hemodynamic respiratory of movement response. So the null monitor is just a monitor that, it's a clever monitor, that measures 4 parameters, temperature, conductance, movement, and photoplethysmography, in order to estimate this vagal tonus. And this is really important because this provides the opportunity to react before the sympathetic activation. And I'm just reaching for the right measure of anti-nociception. And of course, I'm reducing my side effect like we said. I just want to tell you that you need to learn this monitor because it's really a practical one. It's measuring the tonus, the vagal tonus, and that many other things can impact this monitor, but you have to learn how to use it. It's really, really, really simple because in the hand, it's just giving us this index. We have to be above 10 and below 25. What does that mean? Above 25, that means that my patient is a sympathetic part. And for us, that means my surgeon is hurting my patient and I need to give him fentanyl or something else. But also, if I have a null monitor under 10, that means that my patient have more than necessary remifentanil or fentanyl or what you want. And you have to reduce the doses. It's really, really important because it's also a new thing to think like the right measure, not more, not less. So I have 2 questions in order to explain more on the null monitor. Very simple. Who, why? As for who, I need to use the null monitor. For the patient that I have a doubt on my target organ, if I have a patient, drug abuse or chronic pain under opioids, high level, is taking opioids every day, how do I know that I'm doing a good job? How do I know that I'm not giving more or less than necessary? Also, I have a patient with very high blood pressure. Okay, so during the surgery, I will get 170 systolic blood pressure, and I need to differentiate if it's because my nociception and my patient, I need to give him right now fentanyl, or I need to think it's just because it's disease. I have to treat in hemodynamic way and I have to check preload, afterload, and everything. But it's really, really different way of patient of a reaction too. Of course, my elder patient that I need to reduce all the dose and all the side effect. But also, if you have a different category of surgery, if you have a surgery without neuromuscular blockade, maybe it's good to appreciate the vagal tonus, because if my patient is suffering, he will move. Okay. Or second, if I have a laparoscopic trend lumbar surgery, so you do know that we will get hemodynamic changes, and we want to appreciate and treat if it's pain or if it's pain nociception or if it's because hemodynamic changes. So this is the first question. Second, why? Okay, thank you. But why I'm doing this? has two answers. To answer. First, pain. If I want to keep my homeostasis, my equilibrium, so if I'm giving more than necessary opioid, I will get hyperalgesia and chronic pain. So patient came for surgery because pain of organ function, and after the surgery, he will get neuropathic pain. It's not that clever. And if I'm giving less than necessary, I will get central sensitization and also chronic pain. Second answer, hemodynamic. I need the same equilibrium. If I'm giving much more than necessary, I will get hemodynamic instability, hypotension, and I will use vasopressor if needed. But if I'm giving less than necessary, my patient will move, I will get blood pressure fluctuation, and I will get an unhappy surgeon. So this is just 3 little studies to picture my point. On your left, you have anesthesiology that managed to do the surgery with under remifentanil TCI and according to the level of null. And we reduce 30% of the doses. But more than that, we reduce the use of vasopressor. So hemodynamically speaking, every kind of vasopressor, phenylephrine, ephedrine, and everything. On your right, you have 2015 cardiovascular journal. According to the level of remifentanil during the surgery, you will get more pain in the recovery room. You hear me? So I'm giving remifentanil and my patient is more painful. Okay, because the side effects of remifentanil. And we do know now that we need to reduce the doses of remifentanil at the necessary. So, of course, more morphine consumption, more chronic pain, and more hyperalgesia. And the third study from this year too, BGA, we can see now, it's a logical thing, we did know that, but this is evidence-based medicine. 40,000 patient retrospective study, and they just want to appreciate hypotension and cumulative dose of epinephrine lack independent factor of acute kidney injury. And every time that I'm hearing, but for who you want to use it, for me it's very simple. You can see here that because it's an independent factor, we can see here that all the patients as are free and through, maybe, not maybe, they need a null monitor, I think, in order to reduce the amount of hypertension and the use of vasopressor. So it's really, really important to me to think on the target organ and to adapt the monitor to this doubt. Is there a doubt? We can use the null monitor, we can treat the patient, but first to think, we can treat the person by not being iatrogenic, not to give more than necessary drug to the patient. So this is my third video. Maybe someone can help me. Georgios, help me. Hello.
Να παίξουμε λίγο το βίντεο.
Wait, just a second. Pause. As in this video, I just want to share with you the step-by-step approach, and we will have a little exercise of how null monitor is working. Very simple. So you can play the video. Thank you.
At the center today we have total thyroidectomy with a patient in overweight. As we can see, she does have a big goiter. This is the trachea in the middle, and on the sagittal way you can see all along the goiter, left and right. So what I want to show you today is that I have to do the procedure without no-recur blockade. That means that I have to do a sequential assessment, and first of all, I have to see if the sevoflurane if I see in my monitor of this, if I'm in the good shape. Its mean frequency is 12, but I also use ketamine, so that I know it's a little low. Secondly, I have to see on my null monitor if my patient
Just want to remember you, more than 10, less than 25.
He's experiencing a nociception activation, and we are under remifentanil in order to remain my patient stable all along the surgery. So 1.8, and here I can see an elevation. If it's during more than half a minute, I have to increase my remifentanil. Okay, so I repeat. First of all, hypnosis according to the beast. Second, I have the monitor of Noel, and thanks to him, I can do my anesthesia before my patient is waking up, moving, because we are under surgery of the throat. So it's very insecure surgery if she is moving. Last thing I just want to tell you, how can I remain in hemodynamic stability all the surgery? I have to reduce all the secondary effect of my drugs, and thanks to that, I can prevent using vasopressor in order to not to deteriorate my kidney function. And so it's very important to me to appreciate my hemodynamic state, also on the baseline from the blood pressure, second on the wide of the pulse pressure, and third on the perf index that we have here, that can give me the answer, does my drugs influence my systemic vascular resistance?
Okay, as a very quick exercise, just want to show you how it's work in practice, okay? So we get a number of null, and
you can see elevation. So before there is an elevation, I want to wait for, but we have to increase now the remifentanil. And 2, just a little is sufficient, is enough in order to reduce our vagal balance. And you can see here that there is already modification on my pulse pressure, but I'm before is tachycardia activation and my respiratory activation. So this monitor of null is giving me where the balance sympathetic or parasympathetic is before I have hemodynamic respiratory or movement modification. Thank you very much.
This is a screen after surgery. Blood pressure completely stable all over surgery. And this is the way you're using null monitor on everyday practice. So in order to remain on the right level of our drugs. So let's continue.
Hello everyone.
Okay. So now, how much I need to be precise. It's according to, if I'm willing to appreciate every day, my neurologic, my nociception, my hemodynamic state. And I just want to finish with the last part of this presentation with the perspective of the patient. This is a really important study for me, very simple. They ask 20 health patients, to do a trial. So they put them on the MRI machine, and on the ankle they have a heat stimulator. They have been hurting them until pain of 7 on 10, and they ask them how do you feel on a pain scale, on the anxiety scale. So that means that we are hurting them and we are asking them, are you painful or not? And please notify which number. But we have 4 steps. First of all, it was the baseline, and we get 7 on 10 for the average pain. After that, we did the same thing. We gave them a remifentanil infusion, and we told them that it will help them. It's a good opioid. We take care of the pain. It will be great. With smile, and it's help. You can see I have a positive expectancy, and I reduce my pain and I reduce my anxiety. And after that, we have remain 2 measures. First, neutral. I am giving remifentanil and I'm measuring the pain, and it's not changing anything. But more than that, I can tell my patient, we're stopping to give you something to help. Now you just have pain, but we continue to give remifentanil. So according to the way I'm talking to my patient, I have different consequences. And more than that, because we are under MRI, we can do a functional MRI and we can see that we have different area on the brain. And for positive expectation, of course, we have the singular anterior cortex, and we have all the things that we can see on today on the hypnosis and different virtual reality. But if we are on a negative expectation, we have the higher level of pain in every step of this process trial, but my patient is receiving remifentanil, but is not feeling this. It's really, really important to me because we have to be in a humility way. That means that now we have, since my take-home message, my free take-home message, we're becoming more expert. We have more information, but we have to show some humility because we have to connect with the patient. And the first thing to do is to smile to him. And personal anesthesia means personal patient, and really important to me because it's really changed the culture of doing my everyday practice. And also, my second point here, we are changing the way as we are doing a good job. What is for you a satisfaction scale for an anesthesiologist? And until now, I'm going to the recovery room and I'm asking for my patient, do you have pain? And he's telling me on the 0 to 10, 0, and I was satisfied. We were reaching for the holy 0. But 0 pain don't mean that my patient is comfortable at all. And now we are changing this view. We reach for the right measure. We reach for doing the right thing for the patient. And this is leading me to my final conclusion. We expected benefit of your drug. We are giving. We have the most iatrogenic profession on medicine, I think. But when we are giving our drugs, we are reaching for the benefit. But what we are giving in excess, it's become a poison for the patient. So we have to monitor what we are doing, and we have to target the right measure of what we are doing. So it's Latin, primum non nocere. But okay, first, do not harm. So to conclude, in the perspective of the patient, it was a difficulty that it's difficult to me to adapt me to what happened to me. But now it's become a life experience. We need to maintain the autonomy, and we can be the helping doctor and not the one that decides for everything. So thank you very much for your attention, and God bless you all. Thank you.
Dan, first of all, I would like to thank you. That was a marathon, talking 1 hour. It was really tough, but you did very well. Thank you for your fantastic presentation. First of all, as a big fan, I would like to thank you also that you raised the awareness about how and why it's important to monitor the brain and which information we can take from this monitor in order to adjust or manage, our patients better. Έχετε κάποιες ερωτήσεις? Any questions, please? Yes, please.
Congratulations for your very vivid presentation. It was really very interesting.
Thank you.
Now, we use BIS almost in every case. Do you think we should use both monitoring in every case regarding the cost? What do you think about that? Thank you.
So I just want to understand well the question. You mean, do we need to use BIS for every procedure or for every monitor for every procedure? BIS, you... Okay.
For every case, for every patient.
Okay, so that... Okay. So I'm telling you what I'm hearing. In fact, the question for me to the monitor is like that. are the monitor necessary or are they accessory? Or, in other words, is for the security of my patient, so I need to use it, or is for something to improve, something that we are not getting benefit of this. And now I am telling you, it's not just for security, but this is the most powerful thing on my operating room, because I know what I'm doing. I want to reach, I am activist, okay? I want to reach for the right level of hypnosis, and I do know that I'm reducing also my brain or my autonomic complication, but I'm reducing my hemodynamic instability. So for your question, for I don't know how much is it sticker of this, but I don't think it's quite. I think it's worth it, really. So yes, for me, we need to use all the monitor, because if we have a doubt on the target organ, first of all, we have a doubt on the state of hypnosis, and everything starts with the hypnosis. So I will use this for everyone. And for the non-monitor, I can tell you that I'm using it if I have a doubt on the neurologic state, nociception state of my instability, according to the patient of or the surgery. So yes, for the bis, and for the null, it's depending.
Any other questions? Dan, can I ask you, please, something? So, as I said, I'm a big fan of BIS. I use it in every case, every single day. So you show us 3 parameters. We have the index value, right? We have the DSA, and we have the raw EEG. Which one of these is the most important clinical parameter in order to get a significant information? Do you use index value? Do you use raw EEG? Do you use DSA? All of them? 2 of them?
Okay. Okay, so we, on this question, we already use a BIS monitor. And in fact, I'm not taking care of the number. I'm not looking at the number. It's like in the ECG, we are not looking if the patient is 60 or 62. I don't care of it. I must tell you. So what I have to take care? I have to take care of my DSA, and it's a really, really practical thing. I am teaching my residents, and I can see after 10 or 15 cases, they're becoming autonomous. It's really, really a practical tool, the DSA, because we are reaching for colors. Okay, I'm just simplifying the thing, but this is a picture that we have. So I have to. I saw this like zoom in and zoom out. You have the zoom out, the spectrogram, and you have the big pictures, you have the colors, but you have the zoom in if you want to enter the details, to see the different waves, and you can learn with time so much more details. And it's a real time live procedure. You can see the raw EEG moving during the surgery. It's a really another way to see your patient. So if I need to choose, okay, so the number I don't look at him at all, but I will say the spectrogram, because it's really easy for me.
I totally agree with you. Thank you. Any more questions? Right. Thank you for being here. Now I think we have a lunch break.